One of the other major questions that I'm sure you get when you travel around the country talking to people is still, when do you use surgery? Patients present, still about 20 to 25% of patients present with metastatic disease. Some of these are small tumors with distant mets, some of them are big tumors. So most of the trials that have been published, the overwhelming majority of patients were patients that had received cytoreductive nephrectomy prior to a treatment. Some of them in the distant past, some of them in the recent past, and that's part of the risk categorization that both Heng and MSKCC use, which is time from diagnosis to treatment. Monty, is there a policy that you think makes sense about who should have a cytoreductive nephrectomy in the presence of metastatic disease versus who should be treated first? And is the answer really that both ways of approaching the patient might be right, as long as cytoreductive nephrectomy is considered somewhere in the course?
Right, I think the latter of the two, but just to back up for a sec, there are a couple of situations where I feel that cytoreductive nephrectomy is absolutely indicated. So if a patient is resectable and has uncontrollable pain or hematuria, paraneoplastic syndromes, those are definitely patients that I would strongly encourage to get to the operating room. I think in the cytokine era, it was an easy question to answer. We had good data, randomized data to really address this question, and I think we'll be touching on two important European trials, Carmina and Certime, that may address this question in the context of targeted therapy. I did want to bring up a SEER database analysis that we reported last year comparing cytoreductive nephrectomy in the cytokine era versus the targeted therapy era. With all the caveats of SEER, it really did seem as though the benefit from cytoreductive nephrectomy held up over the past decade. And furthermore, at this meeting, we're going to be actually seeing some data from Danny Heng's group, the International MRCC Database Consortium. And again, I would suggest that data also implies a benefit that persists with cytoreductive nephrectomy in folks getting targeted therapies.
So maybe the best way to answer the question, instead of talking about who to use cytoreductive nephrectomy, Dan, is who don't you use cytoreductive nephrectomy? What's the population of patients where you think it is better to start systemic therapy first?
Yeah. Bob, it's a complex question, but I think there's a few cases that it's really important to recognize where surgery might do more harm than good. And I think these are primarily patients that when we look at them, we're concerned they're too frail to recover from surgery. So particularly performance status, hypoalbuminemic patients that have lost a tremendous amount of weight. Patients with pretty significant anemia can also be an indication of that sort of malnourished state, and those patients that are really kind of failing, that if we do surgery, we may never get them to systemic therapy. And I always look at the patient that we're going to take to surgery and make sure I feel comfortable that that's someone who can recover in time to get systemic therapy. Because even these patients with sort of decreased performance status and weight loss and whatnot could benefit in our poor risk model to temsirolimus. So to me, it's always the question, in weighing sort of upfront temsirolimus for that kind of patient versus surgery. So that's one scenario where I think, we really have to be careful. The other is the scenario where the surgery is borderline resectable. So we've got patients where we've got IVC involvement. It's going to be a major surgery, and we're really not sure if that's going to be able to be done. I strongly recommend referral for those patients to a tertiary center where you've got experienced surgeons doing that to really help weigh whether or not that's the right decision. And I think a lot of our community doctors kind of work with us in cases like that. I think the third scenario that we balance out is the patients who have a significant tumor burden of metastatic disease. So patients who've got, half their tumor burden, 2/3 of their tumor burden outside of their kidney, where we're really not cytoreducing their burden that much. In those cases, again, sort of the risk benefit, is it really worth the delay and whatnot? There's a few other cases where, there's either CNS involvement, spinal involvement, or again, I'm concerned there could be sort of impending complications where I'll do treatment to those sites first and then kind of circle back and reconsider the cytoreductive nephrectomy. So those are also kind of special cases. It's really a complex situation. It again gets back to that multidisciplinary care. If you can reproduce that in the community, I strongly encourage that. If not, using your local tertiary care center to help kind of weigh in on those decisions is really helpful.